First of all, I would like to thank the organizers for inviting me to talk about my favorite topic, which is PrEP. I would spend hours talking about PrEP, but don't panic. I'm going to speak for less than 25 minutes. Here are my disclosures. And the agenda for my talk, I will try to answer some questions which could be even asked for potential PrEP users or maybe even for policymakers. And the first issue, this is not a question, it's a statement, it's PrEP works, but the question is always. Another question could be, do we have to worry about safety or collateral damages of the PrEP? Another question could be, is PrEP for everybody? And if I want PrEP, where can I get it? And lastly, what challenges are from my point of view. So let's start, but before, just let me remember that the prevention based on antiretroviral drugs has become a cornerstone of HIV prevention. This is shown in the treatment as prevention strategy. We know that giving treatment, antiretroviral treatment to an HIV positive person, that person is not going to transmit the HIV. Also, if we give ARV after an exposure, also we can avoid this infection. And we know also that giving ARV before an exposition, we also can avoid infection. And why we don't know? I'm not going to say that we have to say goodbye to the condom, because the condom has played and is playing and will play a very important role on the HIV prevention. But looking at the data we saw yesterday, nicely presented by Taimur Nori, that we know that the incidence, HIV incidence, is still increasing in Europe. So I think that something else should be done. Don't you believe? Don't you think so? Otherwise, this trend will be going up, and I think that with PrEP we have a very powerful tool to change this epidemiology. So I said that the PrEP works. We know, all of us know that PrEP works because there are several clinical trials. I'm not going into detail in all of this because it's because of lack of time. But we know that the PrEP has been shown its efficacy in different population groups, in MSM, transgender women, heterosexual men and women, and also in people who inject drugs. Regarding women, there are two studies, the FemPrEP and the VOICE, where there was no efficacy or no protection. And when we look at that, we work out that it was because lack of bad adherence. So if you've seen that in that table, in the FemPrEP and VOICE studies, you can see that the adherence was between 20 and 30%, so very bad adherence, and this is the reason of the lack of efficacy in these clinical trials. But in the rest of clinical trials, it's clearly the efficacy was well known, and the adherence was also higher than 50%. So PrEP works if it's taken. And I'm going to talk just a few minutes about the Hypergate. This is a clinical trial. It's in mainly European, mainly France, and also in Canada was implemented. But most of the rest of the clinical trials are based on the daily dose of tenofovir and intricitabine, the Truvada. But in this case, the principal investigator, who's Jean-Michel Molina from France, thought that, what about these people who don't have sex every day? Yeah, I know it sounds rare, but it's true, and I can tell you. So in this case, in this study, the participants were taking 2 pills between 2 and 24 hours before having sex or having an exposition, and then 1 pill after 24 hours, another one after 48 hours. And they show an efficacy of 86% of reduction in an HIV incidence, which was the same than the PrEP study, the British study, which is quite high impact or quite a high efficacy, no? And because the monitoring committee recommended to stop the study or to open, because it was a double-blinded study. One group received the Truvada and another group received the placebo. But because of the results, the committee advised to open, and then there was an open-label phase. And in this open-label phase, the efficacy was even higher, was 97% of reduction in the incidence versus placebo. So it's clear that the PrEP works in clinical trials, and what about in real world? I'm going to show you one study, it's probably the biggest one I've seen, and was implemented in California with almost 5,000 men, mainly MSM and on PrEP, in that period between July 2012 and 2017, which is almost 5 years, and the results were this: no new infections among these almost 5,000 men on PrEP. If they were not on PrEP, we would expect quite a lot of HIV infections. So also in real world, PrEP works. The next question is, but always work? Does PrEP always work? Well, I have to tell you that so far there have been 6 seroconversions reported. One of them is not clear, probably was already infected, that person was already infected when he started the PrEP. But last week, I was at the ID Week in San Francisco, which is the conference of the Infectious Disease American Society, and was presented this case. It's a 21-year-old Latino MSM who seroconverted at month 13, so 13 months after taking PrEP. And they know that the adherence was good because they analyzed the plasma and also the dry blood spot. And another interesting way of measuring the level, the Truvada levels, the tenofovir levels in this case, which is the segmental hair analysis. In that case, that guy had a long hair, so they were able to analyze up to in the 9 or 10 months, and they detected levels, tenofovir levels. And when they look at the genotype, they saw that there was a mutation, the M184 mutation, and it also was confirmed that it was transmitted, that was developed after the infection, but was transmitted by one of his partners. So this case is not the only one. There is another one which was detected in the demonstration project of Amsterdam, and in this case it's a man, a 50-year-old man with a good adherence also, it was a wild type, so no drug-resistant mutations, but he had multiple sex partners. On average, he had 3 partners, not per month, not per week, but per day, which is not bad. And also, he had a recent rectal STI, a lymphogranuloma venereum, and also he was practicing chemsex. And this is also an interesting study which was published 3 or 4 months ago, showing that the methamphetamine increase the levels of cytokines and other inflammatory markers at local level, at mucosa, at rectal mucus, and that could explain higher susceptibility to HIV infection. So probably in this case, Truvada couldn't cope with all these challenges, and it failed. I'm not going to talk more about more cases. As I said, there are 6, probably 5. But we have to keep in mind that it's estimated that there are around 2,000 200,000 people on PrEP all over the world. So 5-6 seroconversion is not a high proportion, of course. But anyway, individuals on PrEP and healthcare providers should be aware that PrEP failure, it's very rare, but it's not impossible, even with consistent adherence. Next question is PrEP safe? And the answer is yes. We know that there are the bone toxicity or the kidney toxicity. It's been shown in the studies, but I'm not going to go into detail on that. And in some studies have been shown that bone mineral density was decreased by 1%. Most of the time was reversible. And the same for the renal toxicity. There was, in these studies, have shown the reduction of the creatinine clearance, but not an important one. And in that study, in the Bangkok tenofovir study, they showed that this creatinine clearance back to normal and within a median of 20 months. So it's in case there was some kind of renal toxicity, it was reversible. And what about sex? Some people say that if people start taking PrEP, the world is becoming something like Sodom and Gomorrah. Everybody's going to have sex everywhere, at any time, with no fear. And well, let's look at the data. And the studies, in the IPREX study, they didn't see any risk compensation with the PrEP. That means that even the number of receptive anal sex decreased with partners decreased. And it was also, it's a little bit amazing because the proportion of people using condom increased. You must say, well, but this is a clinical trial, this is not real life. Real life probably is different. Yes, I think so. And in another study, the PrEP study, they saw a slight increase of STIs in the group taking on PrEP, but this was not statistically significant, the difference. But we go to the real world. In this study presented at the CROI conference 2 years ago, we can see that people on PrEP had more STIs after starting the PrEP. And also they reported a decrease on the condom use during the anal sex, no? Which doesn't surprise to me. People take PrEP because they want to be more protected and because they are thinking of not using the condom all the time. There are more studies, but I'm not going to spend more time. But one issue which could be concerning, it's hepatitis C. So what's happening with hepatitis C and PrEP? There are a lot of information, but this study, the demonstration study from Amsterdam, show quite high incidence. This study is, there are almost 400 participants, and they observe a prevalence of 4.8% of HCV prevalence, and the incidence was 1 per 100 person year. But the most striking fact is that the reinfection rate was extremely high. It was 25% of reinfection per 100 person per year. But they said that this could be explained because most of the participants did chemsex. 75% of the participants were doing chemsex. But can we do anything about that? And the answer is yes. This is a very interesting study. It's a modeling study showing that the PrEP could reduce the STI incidence. How? Simply by doing a screening. Because if we screen for STIs on a regular basis, ideally on a quarterly basis, every 3 months, we will be able to detect asymptomatic STIs, which most of the STIs are asymptomatic, as you know. So we'll be able to cut the transmission chain. And this study shows how, this modeling study shows how the incidence could be decreased even on people taking on PrEP. And it says that there is no any evidence to support that the increase of STI is because of the PrEP. In fact, I'm going to show you this data is from my country, from Catalonia, and this is the syphilis and gonorrhea and chlamydia evolution through the years from 2006 and 2015. And as you can see, there is an increase of STIs and no PrEP by then, but not even now. We don't have PrEP at the national level. So this increase of STIs precedes the introduction of PrEP, clearly. What about drug resistance? Well, the most of drug resistance could be because that person have started the PrEP already infected, and then can develop some kind of resistance. There are some cases described. That's why it's very important to be sure that when we start the PrEP, that person is not infected. That's why we recommend to use the 4th generation test, and even better, viral load, PCR. That's what we usually do. I'll show you what we do in Barcelona. And PrEP for whom? And just if we look at the guidelines, the first one was the CDC guidelines recommending the PrEP for people at risk, but also the WHO and the European AIDS Society guidelines are very clear, and also some national guidelines. For instance, in Spain we have guidelines recommending PrEP, although the Minister of Health didn't take it into account, but this is another history. And the WHO states clearly that the PrEP should be offered to people at risk, defining at risk as when the HIV incidence is higher than 3%. That says that even being higher than 2% could be also recommendable. And EACS also say that should be recommended to MSM who don't use condom consistently, but even for heterosexual men and women who have partners and don't use condom consistently. And the important issue is because PrEP is not available everywhere, a person who wants to be on PrEP will ask where and where can I get PrEP? Well, it depends on where you live. This is a slide showing the countries where PrEP is available within the national health system. It's on green, on dark green, and on light green countries where there are demonstration projects. And in Europe, the first country with having PrEP available within the national health system was France. They have PrEP from January 2016, was the Minister of Health in November 2016, announced that they were going to have PrEP, and nowadays there are around 10,000 people on PrEP in France, and after that other countries also introduced the PrEP in the national health system, like Belgium, Norway, Scotland, Portugal, and Israel. So if you are lucky to live in a country of this, you can get PrEP within your health system, but if not, then you could participate in one of the demonstration studies, like the Amsterdam one, which I was explaining, which I was talking to you about before, or in England, it just started a few months ago, another demonstration project, which is the IMPACT trial with 10,000 people. In Wales, there is another demonstration project. And in Spain, right now we have 2 demonstration projects. One is sponsored by the Ministry of Health, and another one is sponsored by the Health Department of Catalonia. But if you don't have access to an implementation study, also maybe you could participate in one of the clinical trials. These are the clinical trials, the 3 clinical trials ongoing, most important right now. The Discover study is a non-inferiority study with the FTAF. The objective is to assess the efficacy of the FTAF for PrEP. And it's quite a big study. There are 5,400 participants in the States and Europe. We are one of the participant sites in Barcelona. But there are also 2 interesting clinical trials with long-acting cabotegravir. As Dr. Beck explained before, it's a very, very interesting and promising drug. And unfortunately, these are not implemented in Europe, but only in the States, and the HPTN 083 and the HPTN 084 in Africa with women. So if you cannot get PrEP in your health system, you cannot get PrEP in any demonstration study, you cannot participate in any clinical trial, what can we do? Or what can you do? Well, you can do what we call the informal PrEP, which means that you buy the Truvada online, generic Truvada online, and take it. This is an advert from Dean Street, 56 Dean Street in London. They have opened what they call the PrEP shop, so you can buy there the Truvada for £55 per month, and also you get the follow-up there with the STI screening and all the follow-ups in order to monitor for potential toxicity. There is a web, this I Want PrEP Now, where you can get information, and also you can buy through this web. There are links for buying generic Truvada, and it's around 120 or 130 euros per 3 months of treatment. In Germany, there are some pharmacists who created this program, 50 euros PrEP program. So there are some pharmacies where you can buy Truvada for 50 euros per month. In the Netherlands also you can buy it, and any pharmacy, and Italy also you can buy it. I'm waiting for the next presentation to know more about other countries like Georgia. But what we are doing right now in Barcelona, in BCN Checkpoint, which is a community center, I spent half of my time at the hospital as a physician at the HIV unit, and the other half time in BCN Checkpoint, which is, as I said, a community center. In November last year, we started providing PrEP, either through studies or doing the follow-up of informal PrEP. And right now we have around 700 MSM and transgender women on PrEP. We do the follow-up of these people, and waiting for the decision of the Spanish Ministry of Health regarding the implementation of PrEP. But because the demand it's bigger and bigger, so we have to give some kind of we have to give an answer to these people. No? The challenges, from my point of view, first one is PrEP has to be approved and has to be available within the National Health Services. We cannot have parallel systems. For that, we need a close partnership with the community and a strong political support. We have to increase PrEP awareness among health professionals, but also among people at risk, because not everybody is aware of the potential benefits of PrEP, and even some people still can feel some stigma about PrEP. No? And some people can think that if they take Truvada for PrEP, some people can think that they are already HIV infected, or that they are very promiscuous, and that's why they are on PrEP. So there are still some stigmatization, some stigma around. Yeah? And we have to define appropriate models of care. So where is better to provide PrEP? An STI clinic, a hospital, primary health center, or community-based organizations, and also how to best integrate these PrEP services in the existing services. And we have to monitor and evaluate the PrEP implementation. we have to, also a challenge is the development of new formulas. As Dr. Beck said before, if we are able to protect with an injection every 2 months, for sure many people will prefer that rather than taking a pill every day. So it's still a field this is a very interesting field. And also the other options with the neutralizing antibodies, but this is still on early development phases. And of course, to reduce the cost of drugs for PrEP, because I haven't talked about the cost effectivity, because lack of time, but clearly cost effectivity of PrEP is going to be related to the cost of the drug. Now we have, luckily, we have generic drugs, which has changed the scenario, but with the cost of with a cost of 40 or 30, 40 euros per month, it changed dramatically this cost efficacy ratio. And my last question is, well, we have the evidence, we have that many people are already on PrEP, but what are we waiting for to have PrEP available for everybody and within the national health systems and in a more formal way? Just to finish, to thank to Taimur for some information from ECDC and to my team from BC and Checkpoint. Thank you very much.